So one of the experiences that I get in my job that you don't get is I go to professional meetings like the American Society of Hematology. I'm usually a bump on the wall. But one of the most educating parts of professional events like that for me is just eavesdropping on doctors when they talk to each other, or being a part of a conversation where you really hear what they think and what their hopes and fears are and all of that. And to be honest, when I thought about this segment, and it's just going to be a little bit, I want you to get a sense of what that's like. I want you to get a sense of what it's like to eavesdrop on three really smart people, and here we have no shrinking violets. And that's another reason I thought this would be kind of fun. So I'm going to start out by we'll take about 15 minutes or so, have a little discussion with amongst you, and we're going to eavesdrop.
Very good.
Does that sound good?
Sure. So this is a new segment, from what I understand. So this could be a total failure. I'm going to do my best to make sure it's not. So because we were talking about the clap earlier today, we're going to carry on that theme, and instead of being calling this Ask Dr. Ruth, we're going to say let's ask Dr. Craig and Dr. Monty. And so I'll participate in the questions as well, but I came up with a couple of questions that I thought could start stimulating some conversation. So Craig, I'm going to start with you. And this isn't Stump the Chump, all right? This isn't Stump the Chump.
I don't even get the reference.
No? NPR. No? Okay, it's all right. Yeah, it's all right. All right, so actually, this is exactly what happens at meetings, if you guys want to know. So the first question I have is what's new and what's coming. I think that this is always really exciting. I know that Natalie talked a little bit earlier. I didn't see her entire presentation, but you know, when we're at a meeting, the thing that we're all talking about, what's next, right? And when you guys are coming into clinic and you're saying, hey, listen, what is happening in the field? What can I expect? And I think that in each different phase of a patient's treatment, new things are happening. And so I thought that we could just sort of hit on each one of these spots. Smoldering myeloma, and then we can talk about newly diagnosed and transplant maintenance, and then in the relapse space. And I think that will chew up a few minutes, and there's certainly a lot of information to be covering. So I thought maybe we could start with, you know, the as Craig pointed out, and I pointed out on a slide, the precancers, the MGUS and the smoldering. What's happening in that space, and what do you see coming, Monty?
Do you want me to go first? Okay. So I think from our point of view in the precursor disease state, you know, at our center in Atlanta, you know, Madhav Dodabkar has a trial looking at rifaximin, which is a drug that has almost no side effects. It's FDA approved for irritable bowel syndrome. And it's used, in his view, to change the gut bacteria and to see if that would affect the MGUS that the patient has. And the idea is that certain types of MGUS are likely to be much more responsive to the so-called microbiome in your gut than other types of MGUS. And doing a 2-week exposure to rifaximin might help us understand how the bacteria in your gut can affect the cells in your bone marrow. And that may sound pretty far-fetched to you, but there are some newer treatments that stimulate the immune system where the bacteria in your gut plays a big role in how well these medications are effective in their anti-cancer utilization. The other new thing is that or at least what I think is as a trend that I think will be useful, is that we are getting better and better at looking at patients who have precursor disease and finding predictors of patients who are more likely to develop multiple myeloma than not. And still a long way to go in this, but these prediction algorithms, these little medical calculators that we use, when I see patients with smoldering myeloma, it's so so complex to figure out, are they high risk, are they intermediate high, are they intermediate low, are they low risk, and which points that they used to have, they are assigned to them related to their monoclonal protein, the serum-free light chain ratio, the number of plasma cells in the bone marrow biopsy. All of these come and give me a prediction. Oh, this patient has low risk smoldering myeloma. That's a 4% risk at 2 years, a 15% risk at 4 years. I didn't have anything like that 5 or 10 years ago. And that's all based on publications and looking at data sets over the last 2 years. So I'm hoping that we will get better and better at picking away at patients who have precancerous disease and help better define patients who have aberrant plasma cells that are definitely going to become symptomatic myeloma, and those patients who have immunological abnormalities that are never going to bother the patient, and hence continued follow-up is a waste of time. So trying to, in the smoldering section or the precursor disease section, trying to personalize the way we diagnose and follow patients.
Well, it's hard to follow up on that. So I guess what I'm really excited about when it comes to research for MGUS is this large randomized study that's going on in Iceland, where they're screening a bulk of the population, and they're actually ascertaining whether screening for MGUS improves overall survival, meaning that, by picking myeloma early and are we gonna help people live longer? And it's a very important question. And there are risks and benefits of screening, right? I see a lot of patients who get diagnosed with MGUS, and MGUS is extremely low risk, and they're almost certainly never going to progress, but they experience a lot of existential dread and anxiety, right? So we need to know whether it's worth those risks, the psychological risk, the risk of extra testing, the cost, etc. And this study will definitively answer that. Best case scenario, by picking up MGUS early and by intervening on those patients who are destined to progress early, we can, prevent myeloma from happening. Now, that's a best case scenario. There are many other scenarios that we could find out from this trial, but it is a very robust, large randomized trial that I'm extremely excited about. And then just to sort of echo on as far as smoldering myeloma is concerned, the things that excite me the most about smoldering myeloma are actually not the intervention trials where they're studying different drugs, but actually genomic studies, which sort of Craig hinted at, where we can tease out the smoldering that's destined to remain like MGUS, which is actually MGUS, versus the smoldering that is destined to become myeloma, it just isn't myeloma yet. Those studies are not yet ready for prime time, but they're getting close. And they will be better than our prediction models, because our prediction models, they aren't perfect, right? Even the highest risk patients with smoldering myeloma, there's a small fraction of them that don't progress, right? So we acknowledge that by treating even those highest risk smoldering myeloma patients, we are over-treating a small fraction of patients. So those are the two things that I'm really excited about when it comes to precursor conditions.
I love that. So one of the things that I think may be happening in the precursor state space is that smoldering myeloma might go away as a diagnosis. As both Craig and Monty were referring to, we're better understanding who we need to treat and who we don't. And we may be separating patients into MGUS and those into myeloma. And so it'll be interesting to see if smoldering myeloma as a diagnosis sticks around in the long term. But these are all really interesting concepts. One of the other things that happens in smoldering is, number one, we don't know who to treat. And number two, there's a whole wide range of treatments that are being used in the clinical trial space for patients with smoldering myeloma. Do you guys fall on one end of the spectrum or the other? And by spectrum, I say there's some trials that have shown us that Revlimid may be the right choice for these patients. There's other trials that are looking at, if you have smoldering disease, we're going to give you quad therapy followed by a transplant, basically treating patients as if they have full myeloma. Do you guys fall someplace on that spectrum, or is it controversial in your brain as well?
So this is a very controversial topic. So I guess I'll give my brief opinion on it. I do think that with the type of with the type of modern myeloma therapy and modern myeloma imaging that we have today, the results of previous smoldering myeloma trials are very hard to interpret. And I am not sold on the concept of treating high-risk smoldering myeloma with Revlimid. I personally don't view this as a settled matter, and there are many who actually agree with me. I'm not the only one, but I think it's just very hard to apply the results of some of the older trials to the current infrastructure of myeloma treatment and imaging. A lot of the people who previously we used to call smoldering myeloma actually had myeloma because they weren't getting PET scans, they weren't getting myeloma MRIs, and we were missing lesions because skeletal surveys, they often don't pick up those lesions, right? And then we sort of changed the definition of myeloma in 2014. We expanded the definition of myeloma to include some people who didn't have those classical CRAB, those kidney, calcium, anemia, and bone lesions, but they had, very other findings that indicated they were about to become myeloma. Those patients used to be smoldering, and now they're actually myeloma. So the previous trials that included those patients, it's very hard to interpret the results. So I personally think that there's a lot of room for debate, and it is a very controversial topic. I obviously don't want to impose my values, so I present my, when I meet a patient, I sort of tell them the data, my interpretation, and some of them elect to undergo therapy, which I don't think is wrong. I just think that it's a very contentious, controversial issue with a lot of complex data that's hard to interpret in today's day and age.
I generally agree. I'm lazy. And most of my patients are reluctant to be in the clinic. They didn't want to be there, and they don't want to have interventions. And so 95 out of 100 of them will refuse treatment for smoldering myeloma if they don't have to. And I am right with them on that 100%. There are probably about 5 out of 100 where it's actually less stress for them to be active in their disease. They want to receive something, they want to be aggressive, they want to be at the forefront, they want to do something. And I want to support them and be useful to them in that quest, because for them, it's less stressful and less risky to be active than to be followed. And I think that using lenalidomide or Revlimid as a delay tactic appeals to about 5% of my patients with smoldering myeloma, and I support them with it, but it is certainly a rarity. In this group, though, it does select out for that 5%, and in this room, it may be closer to 15 and 20%, because patients that come to these types of gatherings tend to be more active, and that tends to decrease their stress. And so my job is to talk about risks and benefits and talk about ways that I can be useful in clinic. But I don't think there is one solution that's perfect for every patient.
You brought up a great point. How much information is too much information? So many times you guys are coming to us and you're coming with, you spent a lot of time on the computer and looking at all the data and trying to understand, and you're coming to us and we've had a couple of years of training and can sort of put some different brain power and thoughts behind that data. And one of the things that I really struggle with is saying, how much is too much, and where should you go for your information? And so I have my own thoughts about that, but I'm real curious to hear what you guys tell your patients.
My patients, on average, they come in and they think, and it's so culturally funny to me, because they say to me, before they tell me something they read on the internet, they say, I know I'm not supposed to read on the internet. Like, so many people say that. And it's strange to me, because I'm desperate for them to read on the internet. I am begging them to read, to look, to be engaged, to care about their cancer and their treatment. I love it when you read things on the internet and bring them in. Nothing makes me more overjoyed because that means a patient that's engaged, a patient or caregiver that's engaged. And together, if you're engaged, you live longer. And nothing makes me happier than that. So, I mean, the one thing I enjoyed about being in a breast cancer clinic and training was that something would show up on NBC News Tonight, and that morning you would get hundreds of calls. And many of my myeloma patients still think they have melanoma. And they write it out. I have multiple melanoma. So if you read up on the internet, know I am so excited. And there's so few patients that bring up stuff that they've read, they want to discuss. I'm tickled pink. Because I do this all day long. I was like, oh, you want to bring up this and this trial? I was like, I sing when that happens because it happens once maybe a month. And I'm so excited when it does. So please, and again, this may be different from others here, but I love it if you're engaged, and engaged patients live longer.
So I absolutely agree with Craig here that it is very refreshing when we have patients that are engaged, and I thoroughly enjoy those conversations. I do have some patients here who I have pretty deep, intense conversations. Some of them are philosophical, and it's all about like myeloma and learning more. And I learn more. I've learned a lot from my patients, in the last few years. There are some patients, however, and they probably won't be a lot in this room, who like I would argue that they would benefit from less information, and they tell me, they're like, we only want to know the least amount necessary, and don't burden me with more information. Just tell me what I got to do. I'm not going to look this up online. So I meet people where they're at. Generally, I have an approach that is similar to Craig, but I do encounter patients, I'm sure you do as well. And if they don't want a truckload of information, I'm happy to not sort of give it to them. I do think that it is just so tough, especially when it comes to questions about prognosis, when people ask me. And I think the information that you're going to get online about prognosis, or I just don't think anybody can accurately prognosticate myeloma today. I didn't come up with this, I heard this from somebody else, but prognostication is like looking at the stars, and what you see above is the past, right? So you're seeing statistics of people who haven't been exposed to some of the newer drugs. They didn't live long enough for some of the newer drugs. And then there's some drugs that are going to be approved and they're going to be developed during your lifetime. So any prognosis information is not going to capture that. So I do tell them to take, especially prognostic information, with a grain of salt, because there's literally, I don't think anybody can prognosticate myeloma accurately today. We all try, we have our models, but it is a tough job. So, yeah.
How are we doing?
Finish up. You get the last word.
I don't know if I have a concluding statement. I thought it was successful. Yeah. These guys are talkers, so it made that easy. But I think that next time we should do a little bit longer. I've got a whole laundry list of questions.
You want to tell me to short.
Yeah. Well.
Thank you.